Good morning, everyone. Welcome you all in Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj, and we are discussing this amazing series of INISS Neonatology Fast Track Revision series. In this series, we have discussed neonatal neurology, neonatal GI, and neonatal respiratory part. Now, we will discuss neonatology part of fluid and electrolyte and kidney diseases in newborns. Okay, so this will be again a high yield session. We will cover extra high yield hot points which are important for exam. So I want your 100% attention in this class. Everything I'm discussing is previous year question or upcoming expected question in your exam. So before starting, do like, share and subscribe this channel. And without further delay, we'll start neonatal fluid electrolyte and kidney disorders. Okay, so first thing first, total body water, intracellular fluid and extracellular fluid in a human, how it actually goes. So just remember anything, be total body water, be it intracellular fluid, be it extracellular fluid, it is more in male than female. First thing, total body water is maximum in fetal life, then it decreases after in adulthood life, it also decreases. Coming to intracellular fluid, ICF and extracellular fluid. Okay, in fetal life, extracellular fluid is more than intracellular fluid, which is very much important. After birth, around 3 to 4 months, intracellular fluid and extracellular fluid are at common equilibrium level, are equal. Very important, again MCQ point. After that, intracellular fluid is more than extracellular fluid. So you have to remember this flow chart. This is important. Male total body water, any of water is more than female. Then at 4 to 5 month, or you can say 3 to 4 month, intracellular or extracellular fluids are in equilibrium. In fetal period, ECF is more than ICF, and later life ICF is more than ECF. This diagram also shows this is actually birth weight. It birth weight by percentage birth weight, it decreases and increases. This is extracellular fluid volume. This is the graph of extracellular fluid volume, and just see this graph. This is actually sodium balance. If you carefully look this graph, postnatal 1, 5 and up to 9 to 10 days, sodium balance is negative. So this is negative sodium balance immediately after birth. After 10 day of life, sodium balance comes in positive. We'll discuss this also, but you have to remember these diagrams. Any statement based question or diagram based question can be asked. Okay, so weight loss stages in a newborn, it generally three stages: stage 1, stage 2 or stage 3, or we can call them as phases. Stage 1 or phase 1, there is loss of excess ECF and evaporative water losses from immature skin, leading to maximum weight loss. So this stage is of maximum weight loss. Second phase, in this phase, insensitive water losses reduces at skin barrier matures, urine volume falls to less than 2 ml per kg per hour, and sodium excretion also becomes low. So this is second phase. What happens in third phase? In this phase, it is phase of stable growth characterized by continuous weight gain with a positive net balance of water and sodium, that is after 9 to 10 days, as we discussed in diagram previously. Okay, just one liner and very important in fluid and electrolyte. Just see urine osmolality. What is the lower limit of urine osmolality in newborn? It is 50 millimole per liter. very important. What is the upper limit of urine osmolarity? It is different in preterm and term. In term, it is 800 millimole per liter. In preterm, it is 600 millimole per liter. What is acceptable osmolarity? It is 300 to 400 milliosmol per liter. And what is acceptable urine output? It is 2 to 3 ml per kg per hour. These are fact-based things. You have to remember all these because as a statement-based or fact-based question can be asked from these. Okay, so therefore, after 48 to 72 hours, sodium supplementation should be started after initial diuresis or at least 5 to 6% of weight loss. When you will start sodium in newborn, as we all know, after 48 to 72 hours. Why? Because initial diuresis or 5 to 6% weight loss should be there. Okay. Sodium supplementation, again very important potential question. Sodium supplementation along with breastfeeding might be required in very low birth weight infants till 32 to 34 week of corrected gestational age. Very important. So again, IWL, insensitive water loss, it is 70% is from skin due to evaporation and 30% from respiration. You have to remember these facts. Also, how we can reduce insensible water loss? Important, antenatal corticosteroids add in accelerated skin maturation preterm babies that leads to decreased insensible water loss. Very important. Other we know double wall incubators, radiant warmers, covering head and extremities with cap and socks, topical application of emollients, coconut oil or safflower oil, and humidification of inspiratory gases. Okay, so what is the insensible loss? I'll give two data from Cloharty and AIIMS protocol. What AIIMS protocol says, less than 1 kg child, less than 1000 gram child, insensible water loss is very much, that is 60 to 80 ml per kg per day. It is very much. That's the importance of preserving the water. Okay. Birth weight 1000 to 1500 gram. The insensible water loss is 40 to 60 ml per kg per day. And more than 1500 birth weight 1.5 kg, it is merely 20 ml per kg per day. So you can able to differentiate according to weight. What Cloharty says, if 750 to 1000 gram weight is there, IWL is 82 ml per kg per day. Similarly, 1 kg to 1.2 kg 56, 1.2 to 1.5 kg 46, and more than 1.5 kg it is 26. Okay, if you want to remember rough figures, these should be sufficient, and if you want to remember exact figures, these will be sufficient. You have to remember all this because this is important. Okay, first week, what happened in first week? Okay, so this is again I'm stressing this is very important. You have to give your 100% attention. In any point you feel, just pause this video and rewind it. Okay, going forward at first week, what happened in first week? In first week, it allows ECF contraction. Negative fluid balance less than 10% occur in this phase. Also, negative phase of sodium 2 to 5 millimole per kg per day. As we discussed earlier also, negative balance of sodium is also occur. Avoid oliguria in this phase. You have to avoid transdermal water losses as we discussed also. Okay, so the fluid requirement now we are going. So as we are all familiar with, fluid requirement in term neonate starts from and preterm neonates. Okay, after first postnatal week, we will discuss also in first week also. Just see first postnatal week. Generally, term neonate requires 140 to 160 ml per kg per day, and preterm neonates require 150 to 180 ml per kg per day. Sodium requirement is 2 to 3 millimole per kg per day in term, and 3 to 5 ml millimole per kg per day up to 7 millimole per kg per day in preterm neonate. Just mark it. Okay. Potassium requirement is 1 to 3 millimole per kg per day in term, and in preterm it is 4 millimole per kg per day. So you have to remember. Okay, another practical implication of this, weight loss. Okay, in term neonate, generally what we see in term neonate, 1 to 2% of low weight loss is seen daily, up to 7 to 10% cumulative weight loss in first week should be there. It should not cross more than 10%. But in preterm, generally more losses are there, that is 2 to 3% losses daily, up to 10 to 15% cumulative loss at end of first week. Okay, so these facts you have to remember. Okay, so now we are coming to fluid requirement. Okay, I have simplified this fluid requirement basis on a flow chart. Okay, so just pay your attention. If the baby neonate is term or even the neonate is preterm, but it is having more than 1.5 kg weight, okay, at day 1 what happen? Excretion of solute load approximately is 15 milliosmol per day. Okay, to excrete this solute load, that is 15 milliosmol per day, we will be requiring 50 ml per kg of free water. Along with, if you seen the previous table also, in this IWL, insensitive water loss, is approximately 12 ml per kg post 1.5 kg. So we will add this 50 plus 20, it will translate to 60 to 70 ml per kg per day. So that's how we will get 60 to 70 ml per kg per day at day 1 volume. Okay, question can be asked like, uh, in fact a neonate excretes solute of this much and it requires free water of 100 ml per kg. So what will be the fluid requirement? Okay, so you have to calculate fluid requirement by adding insensitive water loss, that is plus 20. Okay, this is of day 1. Day 2 and day 7, newborn baby is starting having milk. So milk is solute dense. The solute load will increase. That solute load will increase by calculation. We have to increase our fluid by 15 to 20 ml per kg per day. That translates up to 7 days 150 ml per kg per day. That's how it gets calculated. In preterm VLBW infant less than 1.5 kg, day 1 you have to give like 10 to 20 ml per kg per day more. Approximately the round figure is day 1 80 ml per kg per day, and in day 2 and day 7, as skin matures, the it increases by 15 to 20 ml per kg per day, and the requirement is 150 to 180 ml per kg per day, because skin matures fast even in preterm after birth. Okay, so in this table also we have shown this. In term neonate and 1.5 kg, 60 to 80 we will start. We will add 15 to 20 ml per kg per day, and we will reach up to 140 to 160, approximately 150 ml per kg per day at day 7. Similarly, for preterm and less than 1.5 kg, we will start at 80 to 90 ml per kg, and up to we will go 150 to 180 ml per kg. Okay. Electrolyte requirement in this consideration, just remember, no electrolyte supplementation is required in initial 48 hours, because this is a phase of diuresis. After that, sodium requirement is 3 to 4, potassium 1 to 2, and chloride is 3 to 4. We have discussed in term and preterm about this requirement previously also. Okay, so we have to start dextrose infusion, all we know, 4 to 6 milligram per kg per minute, and calcium can be started on day 1. Okay, in certain high risk situation in electrolytes. Okay, Otherwise, electrolyte supplementation is generally not required for first 48 hours. Going forward to serum sodium, which is star topic, actually electrolyte of neonates or pediatrics. Okay, normal sodium levels, we know it is 135 to 145 milliequivalent per liter. Okay, we'll discuss in simplified format because we can't discuss sodium as a whole. It is very vast topic. Just as a neonate point of view, I have simplified this sodium metabolism or sodium disorders into hyponatremia and hypernatremia. Just see, in if hyponatremia is found, just see the weight of neonate. If weight loss along with the hyponatremia is there, so this shows sodium is getting lost. So replace sodium is the answer. But you found hyponatremia, but you found weight gain in that particular neonate. Just see for water excess. You have to fluid restrict the child or neonate, which is very important. So these two approach of hyponatremia depends on weight of neonate. Just remember this. Hypernatremia. Similarly, if you found hypernatremia in a neonate, just see weight loss is there or not. Weight loss plus hypernatremia suggestive of dehydration, my dear friend. You have to correct fluid correction over 48 hours, not fast correction. But hypernatremia along with the weight gain is there. So this is state of salt and water overload both. You have to restrict fluid and sodium both. Okay. So again, pause this video and revise this important flow chart. This will be beneficial for your general pediatrics and neonatology both. So this is simplified presentation of sodium disorders. Okay. Acceptable range, as we discussed also, in urine output is 1 to 3 ml per kg per hour. Specific gravity is 1.005 to 1.012. Osmolality is 100 to 400 milliosmol per liter. So you have to remember these fact-based question. These can be asked. Okay. So hyponatremia, going forward to one step ahead. uh, After this simplified classification, if we go deep into this sodium, because we are preparing for ionolysis, so this depth is required. So hyponatremia, just see, hyponatremia, so you have to exclude pseudo hyponatremia. In which condition pseudo hyponatremia is seen is also independent question. This is hyperlipidemia and hyperproteinemia. Okay, exclude hypertonic hyponatremia, in which condition it is seen increase ECF osmolality due to primarily due to hyperglycemia. So lipids are increasing, proteins are increasing, sugars are increasing. In these conditions, the sodium is falsely low. You have to rule them out. Okay, again divide them: hypovolemic, euvolemic and hypervolemic state of that particular neonate. Just don't get overwhelmed by this chart, just follow me. Okay, hyponatremia you found and hypovolemic infant neonate is there. Okay, just see urine sodium is less than 20. This is clear cut case of extra renal losses, maybe in GI, pleural, ileus, NEC, anything. Just remember till here extra renal losses, other you can figure out. But hyponatremia is there, hypovolemia is there, and urine is less than more than 20 milliequivalent per liter. This particular combination suggestive of renal losses of sodium, that is diuretics, osmotic diuresis, Fanconi, barter, anything which is related to kidney. Simplified thing. You found hyponatremia and euvolemia along with urinary sodium is more than 20. If this combination you are getting, only two differential diagnoses are there: glucocorticoids and thyroid and excess ADH. You have to water restrict this patient. In hypovolemia, obviously you have to do water expansion. Okay. Hypervolemic. Okay, this is interesting. Hyponatremia along with hypervolemia. Along urinary sodium is less than 20 milliequivalent per liter. So these three, if combination is there, so these conditions are edema forming states like CHF, nephrotic syndrome, liver failure, cirrhosis. You have to do sodium and water restriction. And if hyponatremia combined with hypervolemia and urinary sodium is more than 20, if this combination is there, just think of renal failure. It may be of acute and chronic. You have to actually restrict sodium and water in both conditions. Okay, so just pause this video, revise this flow chart again, rewind this video back, and this is actually clear this sodium thing in once for all, because this is an important concept in NICU, PICU and emergency pediatric medicine. Okay, going forward to another question. SIDH criteria. What are the SIDH criteria? SIDH is an important topic for AIIMS examiner. Okay, so first thing, urine osmolarity should be more than 100 milliosmol per kg. Usually it should be more than of plasma. Serum osmolarity should be less than 280 milliosmol per kg, and serum sodium should be less than 135 milliequivalent per liter. Urine sodium is more than 30 milliequivalent per liter. Okay, so just remember these three things. Okay, okay, along with two things are there with them, plus. Okay, what are the plus? Absence of renal, adrenal, thyroid, heart failure, nephrotic syndrome, cirrhosis, diuretic ingestion, and dehydration. Okay, these four things including dehydration should be absent from your patient, along with reversal of sodium wasting and correction of hyponatremia with water restriction. If these are present, you can classify this patient as syndrome of inappropriate antidiuretic hormone secretion, SIADH. So just remember the core criteria of SIADH in form of urine osmolarity, plasma osmolarity, serum sodium and urinary sodium, along with absence of certain features, along with corrective sodium correction of hyponatremia. This will leads to you diagnosis of SIDH. Okay. Now going to another subtopic, composition of intravenous solutions. Normal saline, all we know, it contains 154 milliequivalent per liter of sodium. Chloride is similar. If we go to half NS, it will get half 77 and 77. All we know. What is important for us to remember is ringer lactate. Just see, just remember it. This fluid electrolyte ringer lactate also. Sodium is 130, chloride is 109, potassium is 4, calcium is 3, and lactate is 28. Trust me, this is a favorite question of examiners in MCQ exam, university exam, and NEET SS counseling if it occurs. Okay, so this is very important. Okay. Another subtopic is clinical evaluation of dehydration. So dehydration is quantified as mild dehydration, moderate dehydration, severe dehydration. These are two criterias. Okay, infant up to 1 year, and after 1 year, like older children, adult, it will be classified as a different. Okay, less than 5% if in infant. First we will talk about infant. Less than 5% is mild dehydration, 5 to 10% is moderate dehydration, and more than 10% is severe dehydration. But if we talk about child or adult, less than 3%, not 5%, less than 3% is mild dehydration, 3 to 6% is moderate dehydration, and more than 6% is severe dehydration. So you have to remember this subtopic also. Okay, so laboratory guidelines for fluid electrolyte therapy, just a simple actually explanation of what we have learned So far, fluid should be increased in which conditions? Okay, if your neonate is increased weight loss more than 3% per day or cumulative loss is more than 15 to 20%, give the neonate, give him or her fluids. Okay, if serum sodium is increasing more than 145 milliequivalent per liter, give fluids. If urine specific gravity is more than 1.020 and urine osmolarity is more than 400 milliosmol per liter, so these conditions you have to actually supplement along with decreased urine output of less than 1 ml per kg per hour. So just remember all these. In these conditions your fluid is required or it should be increased. In which condition fluid should be restricted, this is important. Okay, which condition? If decreased weight loss, that is less than 1% per day or cumulative loss less than 5%, decreased sodium in less than 130 milligram per liter in presence of weight loss, no, weight gain. So this is important. Decrease urine specific gravity less than 1.005 or urine osmolarity less than 100 millismol per liter or increase urine output more than 3 ml per kg per hour. Okay, so this is simple, this is logic based. You have to just go through this list once again and you will be good enough to go. Okay, FENA, all we know, this is actually less than 1%. This is pre-renal AKI. Level 2.5%, it is acute kidney injury. Okay, more than 2.5% is frequently seen in infant less than 32 week of gestation. I want to draw your attention to this line. Level more than 2.5% is frequently seen in infant less than 32 week of gestation. Okay, now going to acid-base disorders. Okay, see, acid-base disorders are out of the scope of this neonatology revision. We'll discuss them in separate in emergency or pediatric emergency videos. Okay, but as of now, just remember this diagram. Okay, so this diagram is simple. If you are familiar with, arterial pH are given on x-axis and arterial plasma bicarbonate concentration are given on this condition, this y-axis. Along this y-axis is PCO2. So this is actually normal, and in this limb metabolic acidosis, chronic respiratory acidosis, acute respiratory acidosis, metabolic alkalosis, chronic respiratory alkalosis, and acute respiratory alkalosis. Okay, so this diagram can be given and they can ask what this is, this chronic respiratory acidosis. Okay, so just remember this diagram. This is simple, nothing, any mathematics is used. Okay, all you are aware of compensation. I hope if you are doing pediatrics or pediatric graduates, this is important thing. So this compensation, metabolic acidosis, this formula PCO2 is 1.5 into bicarb plus 8 plus minus 2. Metabolic alkalosis, PCO2 increased by 7 mg each, 10 milliequivalent per liter increase in serum bicarb. Along with respiratory acidosis, acute chronic, you have to remember this. I just remember this like 1 3.5 and 2 and 4. Okay, so this is how you can remember. uh, just see how we can remember this respiratory alkalosis by this simple table. Okay, so this is actually 1 3.5 and 2 or 4. Okay, just put here respiratory or alkalosis or acidosis, acute and chronic. By this you can remember. What I want to convey, just remember this table, figures, and actually formula, because this is very important. Okay, so how you will classify acid-base disorders, or you will go beyond this? This is a simple explanation. I will not go into depth of it. Okay, so just see the pH is acidic or alkaline. If you found acidic pH, good enough. You see, if bicarb is decreasing or PCO2 is increasing, there are two causes. If bicarb is decreasing, it will be metabolic acidosis, simple. If PCO2 is increasing, it will be respiratory acidosis. After step 2, just see compensation. Okay, metabolic acidosis you found, low PCO2 is there. It will be mixed metabolic acidosis and respiratory alkalosis. But expected PCO2 is, this is simple metabolic acidosis. And high PCO2, that is mixed metabolic acidosis and respiratory acidosis. Similarly, when you screen this chart, this is simplified chart. I will not explain this chart in detail. Just pause this video and see this chart. Okay, so this how by simple methods, by this chart and by these compensation, you can solve any ABG question in nutshell. Okay, so just pause this video and practice after this class of ABG disorders. It will be helpful. Going forward to hypoglycemia. I don't know, this is actually most favorite topic of AIIMS examiners. First thing first, what is the definition of hypoglycemia in neonates? First, we'll see what WHO says. WHO say blood glucose less than 45. But we don't follow this. We follow operational threshold, which is also followed by AIIMS. Okay, what threshold says, in this condition, if blood glucose is less than 40 or plasma glucose is less than 45, it will be called as hypoglycemia. Just remember, operational threshold, which is also AIIMS definition, blood glucose in any neonate less than 40 and plasma glucose less than 45. But you have to be aware of a term, that is transient neonatal hypoglycemia. What it is, after 1 to 2 hours of birth, it goes as low as 30 milligram per deciliter. So this is transient hypoglycemia. We don't have to worry, just feed the baby. Okay, so before discharge, okay, any neonate of hypoglycemia, just see if that neonate is able to maintain this plasma glucose is more than 70 milligram per deciliter. If one feed is missed, that is ability of tolerate fasting for 6 to 8 hours before discharge, very much important. This is most common cause of readmission for hypoglycemia. If you are sending a neonate of hypoglycemia home, just see, skip one feed. If blood sugar level are more than 70, then you can, after skipping a feed, then you can send that patient home. That is as simple as that. What are the causes of neonatal hypoglycemia? This is again very much important. Some are transient cause. Okay, we'll discuss them. Some are transient cause, like infant of diabetic mother, intrapartum dextrose infusion to mother, stress and SGA. So these are transient causes. What are the permanent causes of neonatal hyperglycemia? Potassium ATP channel defect, just remember glutamase dehydrogenase activating mutation. Okay, I am telling you important ones. HNF1A or HNF4A pathogenic variant, uncoupling protein 2 UCP2 pathogenic variant, along with some syndromes are associated with neonatal hypoglycemia, that is back with Wiedemann syndrome. Okay, hyperinsulinemia in congenital disorder of glycosylation and MAN1. So at least in permanent, you have to remember these because these are important, and some of these are actually asked in exam, other are potential MCQs. Normoinsulinemia, insulin is normal in this condition. The transient one are developmental immaturity to adaptation, that is sufficient self-explanatory, increased metabolic expenditure, okay, and permanent condition like hypopituitarism, okay, primary adrenal insufficiency and some inborn error of metabolism. Okay, just remember these are enough for your exam. Okay, this chart is important. What this chart shows, this shows indication of routine blood glucose screening. You will not screen every neonate in your nursery or your postnatal wards whom you will screen for blood glucose. If birth weight is less than 2 kg, you will screen that patient. If gestational age is more than 30, less than 35 weeks, you will do it. SGA, IDM, obviously you will do. LG babies, you will do. A neonate with RH hemolytic disease, you will screen. A neonate born to mother receiving therapy with terbutaline, propranolol, labetalol, oral hypoglycemic, you will do. Okay, a neonate with morphological features of IUGR, you will do. Just remember. Okay, any sick neonate like parental asphyxia, polycythemia, sepsis, you have to do. Family history of genetic form of hypoglycemia, you will do. Congenital syndromes like Beckwith-Wiedemann syndrome, okay, and neonatal total TP and nutrition. Okay, so in this table, just see which is I'm highlighting. These are important. Okay, every topic is in IUGR, every indication is important, but these are important. Other are self-explanatory. In these conditions, you actually screen the child for blood glucose. What should be the schedule of blood glucose monitoring? Again, very much important. At risk neonates like these. Okay, what is the time schedule? 2 hours, 6 hours, 12 hours, 24, 48, and 72 hours. Okay, so all you are familiar with this schedule also, I think. So just remember 2 hours, 6 hours, 12 hours, 24 hours, 48 hours, and 72 hours. In sick neonates, this will not go well. Just screen them every 6 to 8 hourly. Okay, neonate on parental nutrition. Initially, you have to screen them every 6 to 8 hours for 72 hours. After 72 hours, just screen them once a day. Okay. So, generally, what we use for determination of blood glucose or glucose in neonates, this is glucometer. What the mechanism behind this? It is point of care reagent strip. This can be asked. It works on glucose oxidase method, but it is unreliable in blood glucose level of less than 40 to 50. So, this is important. Okay. What is the gold standard for estimation of blood glucose in neonate or children? This is lab value that use calorimetric method. Again important, this is glucose oxidase method, but it use calorimetric method. ABG machine, you also see blood glucose value. Generally, they are not reliable because they use glucose electrode methods. Okay, so you did blood glucose in laboratory value. If it is the newborn is asymptomatic, but you found blood sugar is less than 40, you will say this neonate is asymptomatic hypoglycemia. Okay, no clinical features are there, but similar value if you found less than 40 milligram per deciliter, patient is having unit is having symptoms, this will be called as symptomatic hypoglycemia. Okay, now we will discuss this table. I think in every exam, if one question hypoglycemia management is there, I will simplify this table or actually flow chart. Okay, we did blood sugar estimation of a neonate. Okay, it was less than 40, like 30, 20, anything. It was less than 40. Just see first step. If the neonate is asymptomatic or symptomatic, if your neonate is symptomatic means apnea is there or seizures are there or any respiratory difficulty is there, just first step, just give 2 ml per kg of 10% glucose bolus. Okay, so what I have written here, bolus is given only in symptomatic hypoglycemia neonates. So in option, if bolus is mentioned anywhere, it will be given only to symptomatic hypoglycemic neonates, not elsewhere. Okay. After giving bolus, you have to start glucose infusion. Okay. So this is glucose infusion. But in asymptomatic patient, when you will start, you will not give bolus in asymptomatic neonate, agree. But when you will start glucose infusion, if asymptomatic neonate having less than 20 milligram per deciliter of sugar, you will start glucose infusion at 6 milligram per kg per minute, not bolus, just infusion. Okay. But asymptomatic neonate, the sugar is 20 to 40, let's say it is 30, give him or her oral feeds, monitor blood sugar after 1 hour. Okay. And after 1 hour, if it is less than 40, just start glucose infusion. So in crux, what I have written here, this is important, this is crux. Okay, bolus we have discussed. Bolus we have to give in symptomatic newborn. But what about IV infusion of glucose? There are three indications. Okay, what are the three indications? First, symptomatic, okay, first, symptomatic hypoglycemia after bolus. Okay, first thing, symptomatic hyperglycemia after bolus. Second thing, asymptomatic hypoglycemia in which sugars are less than 20, just start infusion. And third, blood sugar is less than 40 milligram deciliter after 1 hour trial of feed in asymptomatic hypoglycemia. So these are only three indication of starting IV infusion in newborns. Okay, so at least 4 to 5 questions are framed according to this options clinical scenario. If your concepts are clear, you can answer any question in for hypoglycemia in this table. Okay, going forward, if asymptomatic limb we are discussing. Okay, asymptomatic limb, you monitored blood glucose. If it is more than 40, you have to give frequent feed, monitor blood sugar 6 hourly, stop after 48 hours, and before discharge, ensure there is no feeding difficulty. So this limb is simple. Symptomatic seizures we have discussed, we have to give bolus, IV infusion. After IV infusion, just see blood sugar is more than 50 or less than 50. Okay, if more than 50 is there, okay, just see stable for 24 hours, weaning by 2 milligram per kg per minute every 6 hours, give oral feed, stop IV fluids when rate is 4 milligram per kg per minute and infant is stable, and stop monitoring when two values are more than 50 on full oral feeds. In this limb, after starting infusion, still blood sugar less than 50, increase glucose by 2 milligram per kg per minute till euglycemia, and increase till glucose infusion rate is more than 12 milligram per minute. If you are going beyond that, more than 12 milligram per minute, you have to actually go for further investigation. We'll discuss them brief. What I want to convey from this simple looking flowchart, it is important to consider it as a like clinical scenario base. Okay. What is resistant or recurrent hypoglycemia? In this condition, blood glucose level despite of GIR is more than 12 milligram per kg per minute, or when stabilization is not achieved by 7 days of therapy. So this definition is important. In this condition, what you will do, you will send critical sample but at the time of hypoglycemia, all we know. Okay, in critical sample, what you will send? Serum insulin levels, serum cortisol, growth hormone level, or insulin growth like factors. Along with, we can send serum ammonia and galactose 1 phosphatidylurityl transferase level TMS also. But how you will interpret them, it is very important. So diagnostic criteria of hyperinsulinism has been asked many times. What are these? Insulin is more than 2 UIU per ml. Beta hydroxybutyrate is less than 1.8 millimole per liter. Free fatty acid is less than 1.7 millimole per liter. Glucagon stimulation test rises of more than 30 milligram per deciliter. IGF BP1 is less than 110 nanogram per ml. Unfortunately, you have to remember all these values because they are frequently tested. What are the diagnostic criteria of hyperinsulinism? Okay, so the sample should be taken at the time of hypoglycemia. I have actually collected some GIR formula, infusion rate formula. I am actually hopeful you are aware of these formula because these are important or most commonly used formula in nurseries and ICUs. So just go through them. Okay, so what are the treatment plan of resistant hypoglycemia? First drug like we can give hydrocot. What is the dose of hydrocot? 10 milligram per kg BD. Okay, routes are per oral or IV. What it does, it reduces peripheral glucose utilization. That is the main mechanism. Other drug, digoxide, very important. Dose you have to remember 5 to 15 milligram per kg per TDS, and remember it is oral dose. Just also remember what is the mode of action. This is potassium channel agonist, and also remember side effect of this important drug: fluid retention, hypertrichosis, and cardiac failure. Okay, octreotide dose you have to remember in this 5 to 35 mcg per kg per day. This is subcute, again very important. This is what it is, somatostatin analog. And what are the side effects? Cholelithiasis, transient growth impairment, and tachyphylaxis. Okay, other drug is glucagon. Okay, what is the dose? 0.2 milligram per kg. It should be given as subcutaneous, intramuscular. Mode of action is glycogenolysis, increased gluconeogenesis, and side effects are nausea, vomiting, and rebound hypoglycemia. Okay, so you have to remember this table along with doses and mechanism action. This is important. Okay, we'll talk about brief about hyperglycemia definition. We'll not go about management. Blood glucose is more than 125 milligram per deciliter. It is hyperglycemia. Plasma glucose is more than 150 to 180 milligram per deciliter. It is hyperglycemia. Neonatal diabetes mellitus is a huge, vast topic. We'll just discuss three important genetic pointers in neonatal diabetes mellitus: ATP sensitive potassium channel mutation, KCNJ11 mutation, and ABCC8 gene mutation. Okay, so these are important or most important mutation in neonatal diabetes mellitus. Okay, going forward to another electrolyte which is often confusing. Okay, so calcium. Just pay your 100% attention from this slide. This is important, and calcium is actually you have to understand this. So one question is, what is the fetal calcium? Fetal calcium is 10 to 11 milligram per deciliter at term. Okay. Maternal fetal calcium ratio, what it is? It is 1:4. So these two fact-based question you have to remember. What happen in utero? Placenta is impermeable to PTH and calcitonin, but PTH related peptides can pass through placenta. So placenta is impermeable to PTH and calcitonin. Okay, after birth, when these PTH and calcitonin can travel across, serum calcium levels are go drastically down, and nadir is 7.5 to 8.5 milligram per deciliter in term by day 2. Okay, this is important. After that, PTH increase because it senses hypocalcemia, and normal calcium is reaches by 3 to 4 days of life. So these two things are important when physiological nadir occur at day 2, and day 3 or to 4 life normal calcium is achieved. Okay, renal handling of calcium, it takes 2 to 4 weeks to get mature. By these all factors, neonates are actually increased risk of early onset hypocalcemia, specifically the preterm or septic newborns. Okay, having said that, body calcium is generally found in skeleton. It is in skeleton, it is 99% in bones. Only 1% of fraction seen in ECF, extracellular fluid. In 1%, free ionized calcium is 50%, with albumin it is 40%, and anion, other anion, it is 10%. So this is importance of measuring free ionized calcium, because total calcium is also associated with albumin. Okay, going forward, this is important. Definition of hypocalcemia. Okay, total serum calcium, you have to remember preterm definition and term definition. No excuses in this definition. Less than 7 milligram per deciliter in preterm total serum calcium. If you measure ionic, less than 4 milligram per deciliter. Okay, and term less than 8 and less than 4.8. Okay, so what happened? Sometime they ask this in milli equivalent per liter. Just don't get like surprised in exam. Just divide it by 4. Okay, so like 8 divided by 4, it will be 2. Okay, so for millimole per liter, you have to divide concentration of calcium, or like a milligram per deciliter, divided by 4. Okay, so this definition you have to remember. What are the causes of early onset hypocalcemia? Prematurity, preeclampsia, IDM, stress, asphyxia, maternal intake of anticonvulsant, hyperparathyroidism, and heterogenic, you have to remember. In this slide, I want to remember the definition of hypocalcemia in preterm and term neonates in form of ionized and total calcium, and also in millimole per liter. Going forward to how you will diagnose. Okay, so by measuring total or ionized serum calcium, we have seen, and just see in this, if you do ECG actually QOTC interval is more than 0.22 second, and QTC interval is more than 4.45 seconds. Very much important. What is QTC interval? This is also important. QT interval in second upon RR interval in second. Okay, so this is, you have to remember according to this, because this was previous year question. The QT interval they have asked in hypocalcemia. Going forward to prolonged or resistant hypocalcemia, in this condition, what you will see: symptomatic hypocalcemia unresponsive for adequate calcium therapy, infant needing calcium supplementation beyond 72 hours, and hypocalcemia presenting at the end of first week. Okay, so these infants should be investigated for late onset hypocalcemia. You have to remember this. Okay, so in actually management point of view, practical point of view, I have simplified this hypocalcemia in neonate by simplified manner, as we did in like hypoglycemia or hyponatremia. If you found your neonate is asymptomatic, that is asymptomatic hypocalcemia, in this condition you have to actually give 80 milligram per kg per day calcium for 48 hours. Okay, that will translate to 8 ml per kg per day of 10% calcium gluconate. After this, taper this half of this in next 24 hours and then stop. Okay, but you found your neonate is having symptomatic hypoglycemia similar to symptomatic hypoglycemia. In this also, you have to give 2 ml per kg of 1:1 diluted in 5% dextrose calcium bolus in 10 minutes under strict cardiac monitoring. This step is important. After this step, other steps are same, like continue IV at 80 milligram per kg per day to 48 hours, then taper. So crux of this slide is you have to give bolus in symptomatic hypocalcemia. After that, you have to give maintenance. Okay, if oral intake is good, you have to give oral calcium. Okay, uh, one important previous PYQ question: for severe hypocalcemia along with cardiac dysfunction, in in place of calcium gluconate, you have to prefer calcium chloride, which is important. So this how we will approach hypoglycemia in neonates. Okay, so what are the late onset of hypocalcemia causes? So just see increased phosphate load cow milk. You might actually encounter this in your OPD settings. Patient neonate is on cow milk will lead to late onset hypocalcemia. Hypomagnesemia, obviously, vitamin D deficiency, maternal vitamin D deficiency, malabsorption, PTH resistance, hypoparathyroidism, autosomal dominant hypocalcemic hypercalciuria and heterogenic. Just remember the important which I highlighted for you. So these you have to remember. Okay, for late onset hypocalcemia. Okay, so what are the investigations suggestive required in late onset hypocalcemia? First line you have to remember, note second line. Serum phosphate, serum alkaline phosphate, liver function test, renal function test, X-ray chest and wrist, arterial pH. Other investigation including vitamin D, magnesium, PTH will be second line. So they can ask which are the first line investigation in late onset hypocalcemia of neonates. I'm going very fast because it is impossible to cover so much stuff which is actually important in neonatal, this fluid electrolyte and kidney disorders. Okay, so interpretation of investigation. This is actually ultra important, and actually it will take another full lecture to explain this congestive looking table. Just as of now, remember hypoparathyroidism is high phosphate, other things are low. Pseudo hypoparathyroidism, in this serum alkaline phosphate is high, PTH is high, phosphate is high, but vitamin D is low. Chronic renal failure, in this condition, high phosphate, serum alkaline phosphate will be high, PTH, deranged RFT, low will be 25 hydroxy vitamin D and pH. Hypomagnesemia, you will see PTH will be high and phosphate will be low, magnesium and 25 hydroxy vitamin D. Vitamin D dependent rickets type 1, serum alkaline phosphate and PTH will be high, phosphate and vitamin D will be low, VDDR high SAP, 25 hydroxy vitamin D, PTH and low phosphate. If you are actually thorough in your concepts of these, how these are actually going up and down, just remember this slide. This is crux of all your understanding. In exam, you have to remember this eventually. Okay, going forward to kidney part, neonatal AKI classification. Okay, it will be classified based on serum creatinine and urine output stages like 0, 1, 2, 3. You have to remember three stages. Similarly, we have discussed this in nephro part also. Okay, so stage 1, if urine output, first we'll talk about urine output. Stage 1, if urine output is less than 1 ml per kg per hour, clear. Stage 2, it is 0.5 ml per kg per hour, and stage 3 less than 0.3 ml per kg per hour. It is not that simple, actually it is classified as hours also, but for simplification we'll discuss it. Less than 1, less than 0.5 and less than 0.3, stage 1, 2, 3 respectively. Okay, uh, if we talk about serum creatinine, so rise in creatinine by 0.3 milligram per deciliter within 48 hours, or 1.5 to 2 times, 2 to 3 times, and more than 3 times, or more than 2.5 milligram per deciliter, or initiation of dialysis. So you have to actually remember all these which are important. More than 348 hours, these value you have to remember. Just pause this video and just actually revise this classification of a neonatal AKI, which is important, can be asked in exam, generally routinely asked in exam. Okay, so urinary sodium is in pre-renal less than 20, all we know. Renal failure index is less than 1. In pre-renal intrinsic, it will be more than 4. FANA is less than 1 in pre-renal, and intrinsic renal it will be more than 3. Renal failure index and FANA definition, you have to remember. They can ask, just go through urine sodium into serum create upon urine create is the definition of renal failure index. Okay, and FANA all we know. Okay, so just remember, this can be asked in your exam. Okay, so if a neonate presents with acute kidney injury, what you will do? You will assess and correct dehydration, check predisposing condition for hypotension, avoid nephrotoxic agents, monitor serum electrolytes every 6 hourly, monitor weight every 12 hourly, replace insensible losses, adequate nutrition you have to give. Okay, then you have to do USG focus if required. Give normal NS bolus 10 mg per kg over 20 minutes and IV Lasix, that is furosemide 1 mg per kg as infusion over 20 minutes. After giving bolus and Lasix, if urine output is more than 1 ml per kg per hour, it should be pre-renal failure. But if it is not coming down or urine output is less than 1 ml per kg per hour, still it will be intrinsic renal failure and you have to think of early renal replacement therapy. So this is simplified diagram of acute kidney injury. Okay. So, renal replacement therapy, in which condition neonate renal replacement therapy is required. This is actually a rough chart directly from AIIMS protocol. Hyperkalemia, they haven't mentioned the value. Hyponatremia with volume overload. Metabolic acidosis, pH less than 7.20 despite medical management. Hypocalcemia, hyperphosphatemia refractory to therapy, and inability to provide adequate nutrition due to fluid restriction. Okay, so we'll go to antenatal hydronephrosis. Before that, I'll be starting a series which will be audio series for Journal Pediatrics revision. It will be fast with audio series. You have to just plug your earphone in and just a short video series. It will be around 30 seconds to 1 minute. I'll be discussing important exam topics of Journal Pediatric part of this INISS neonatology exam. So it will be live soon. If you are interested in this, we'll do this in a full syllabus manner. Let me know in comments if you're interested for that. Okay, going forward, hydronephrosis. This is important. This chart is actually having 3 to 4 questions in it. Okay, so I'll go slow in this. Okay, just pay your attention. You did USG, antenatal USG, and you found antenatal hydronephrosis. Good. Okay, your baby is born. So after baby is born, perform postnatal USG of KUG. You send the patient neonate to USG. Okay, within when you'll do within 24 to 48 hours of birth, if LUTO means obstruction is there or bilateral severe hydronephrosis or single kidney, and before 2 to 7 days before discharge in other cases. So one question, antenatal hydronephrosis, when you will do USG. So this is important. This is okay. What are the indication of immediate or within 24 to 48 hours of post birth doing USG in antenatal hydronephrosis neonates, which are LUTO first, bilateral severe hydronephrosis second, and single kidneys third. PYQ question. Okay, in other cases you have to do after 2 to 7 days. Okay, you did USG and report came in front of you. Okay, first scenario, no hydronephrosis, SFU grade 0 or UTD pure, APD less than 7 millimeter. I'll discuss them. What are these? Okay, before going this chart again, going forward, we'll discuss some term, we'll understand some terms. Okay, so lower urinary tract infection, obstruction, sorry, they will ask what it is defined as bilateral hydrouretonephrosis along with oligohydramnios, bladder wall thickening, and or dilatation. So definition of lower urinary tract obstruction you have to be well versed with, because this is previous year exam question. Definition of LUTO. We have discussed SFU staging in this flowchart. We'll understand this SFU staging. Okay, so SFU staging of hydronephrosis is actually grade 0. No splitting of renal pelvis is seen in 0. Urine in pelvis barely splits pelvis, stage 1. Grade 2, Urine fills intra-renal pelvis plus minus extra-renal pelvis and one or few major calyces are dilated. Grade 3, SFU grade 2 and minor calyces uniformly dilated in normal parenchymal thickness. And grade 4, SFU grade 3rd and thin parenchyma. Okay, so this is important. If thin parenchyma is given, it is grade 4. Okay, just pause this video and just revise this because this is important, ultra important. Okay, urinary tract dilatation, UTD classification also you have to remember. Okay, in this condition, UTD PO, P1, P2, P3. In this condition, APD diameter is less than 10, APD 10 to 15, and in this condition, APD more than 15. Okay, and UPD P3, in this condition, central peripheral calyces, abnormal ureter bladder, abnormal renal parenchymal thickness, and APD more than 15 millimeter. Grading of VUR, I think you are all aware. I will not go into grading of VUR. If you want to see this, just go to my nephrology lectures in this playlist of Nelson. Okay, so as of now, this looks very overwhelming. Just pause this video and revise this staging. After you have done, just revise this slide. We'll go back to this slide. Okay, so where we are, we did USG. Okay, in USG you found no hydronephrosis, SFU grade is 0 or UTDPO 0 and APD less than 7 millimeter. What you'll do, important thing, you'll do USG after 4 to 6 week. Okay, and if it is normal, so you'll go according to this. Okay, I'm directly going to the right part of this flow chart. If you found features of LUTO, what are the features of LUTO? You have to remember bilateral hydronephrosis with oligohydramnios, bladder wall thickening, and or dilatation. So if you found features of LUTO, okay, just remember previous year question, you have to do your MCU within 48 hours. Okay, if doing MCU, no LUT or no lower urinary tract obstruction present, it's okay. If it is present, refer to pediatric surgeon. But if it is present, then you have to again do MCU at 4. You have to do MCU at 4 to 6 week. Okay, so this part we have covered. Okay, another part like unilateral bilateral hydronephrosis you found, but lower urinary tract obstructions are unlikely in this condition. See SFU grade if it is grade 1 or 2 or 2 or 3, UTD P1 or UTD P2 P3, APD less than 10 or APD more than 10. You have to divide into 2. In first case scenario, you have to do USG monitoring at 4 to 6 weeks, then every 6 to 12 months until resolution. Okay, but if it is as this stem is there, SFUs 3, 4, APD more than 10, UTD P2, P3, and in this limb also lower urinary tract obstruction is absent. In this condition you have to do MCU. Just see if VUR is present or not. If VUR is present, see if it is grade 1 or grade 2. If it is grade 1 or grade 2, you have to do USG monitoring 6 to 12 months until resolution. And if it is of grade 3 or 4, you have to give antibiotic prophylaxis. Okay, if you found MCU is normal in these two scenarios, means in these two scenario, sorry, in these two LUTO absent or this scenario, you did MCU, you found there is no VUR, what you will do? You will go for renal dynamic scan at 6 to 8 week. So this is last limb of this exhaustive looking actually flow chart. You'll see non-obstructive pattern and obstructive pattern, along with you will go for like uh, other things you will see. Pyeloplasty indication has been asked in exam. So what, when you will do pyeloplasty, if obstructive pattern with split renal function of less than 40%, deteriorating split renal function or deteriorating hydronephrosis are the indication of pyeloplasty in case of antenatally detected hydronephrosis. So my advice is pause this video, rewind this video and clear this thing once and for all by going back and forth. Okay, so this is important. Okay, so we'll talk something about PUV. So just some points PUV. In PUV, this is PUV is most common lower tract urinary obstruction of children. One question. Type 1, it is 3 category. Type 1 is most common. This is also PYQ. Type 2 and type 3. Type 1 is 90 to 95%, and type 2 is no longer form of PUV, and type 3 is 5 to 10%. So type 1 is composed of a RIS. Okay, type 2 is not longer considered for PUV. Okay, it is generally it is called as artifact, which extend from verumentum to internal sphincter or bladder neck. And type 3, it is found at various level of posterior urethra that forms a diaphragm with small opening in the center. So you have to remember all this because this actually this has been asked in exam. Type 2, type 3. Okay, this is most common cause of lower urinary tract obstruction. Okay, if you found like PUV, so what you'll do, clinical examination. Okay, if your neonate is stable and cystoscope is negotiable through urethral opening, what you will do, cystoscopic wall ablation. After ablation, obviously you have to do monitor kidney function and check cystoscopy after 3 months. But if your neonate is unstable and urethral opening is too small to pass a catheter for fulguration, what you'll do, bladder drainage by suprapubic catheterization or vesicostomy. Okay, so you have to do high urinary diversion and ureterostomy closure later. So this how we will go PUB surgically. Okay, extra age I'm discussing. Okay, some syndromes are associated with renal abnormalities in children. Very just see this is extra age. If you want to cover this, it's good enough. Otherwise, what we have discussed is good enough for exam. Okay, so oligohydramnios Porter sequence in we all know altered facies, pulmonary hypoplasia, abnormal limb and head position. What are the renal abnormalities? Renal agenesis, severe bilateral obstruction. Generally, these are most common. Vectoral anomaly, vectoral, all we know. What are the kidney anomalies in this? Renal agenesis, renal dysplasia, Mullerian or MRKH syndrome. This is MRKH. Okay, I'll not discuss MRKH syndrome in detail, but in MRKH syndrome, renal hypoplasia, agenesis is seen. Prune-Bailey syndrome, that is hypoplasia of abdominal muscles. All we know what seen in this as a kidney point of view, megaureter, hydronephrosis, dysplastic artery. Okay, spina bifida, neurogenic bladder, vesicuretary reflex and hydronephrosis is seen. Similarly, coda dysplasia in this caudal regression syndrome. Okay, neurogenic bladder is seen, vesicuretary reflex is seen. Anal atresia, that is high imperforate anus. In this condition, PYQ question, renal agenesis and renal dysplasia is seen. Hemihypertrophy, Wilms tumor, hypospadiasis, we all are aware. Aniridia, Wilms tumor, Dash syndrome, Dehydration syndrome, mesenteric sclerosis and Wilms tumor. We have discussed this DRAS syndrome under heading of nephrology. You can go through in my videos and playlist. Small deformed or low set ES in renal agenesis or dysplasia. Okay, uh, Zellweger syndrome, that is cerebrohepatorenal syndrome. Cortical renal cysts are found. I'll discuss important renal manifestations only. If you want to go through general features, you can go. Janus syndrome, it was previous NEET assess question also. Asphyxiating thoracic dystrophy, what found in kidney, cystic tubular dysplasia, glomerulosclerosis, hydronephrosis. Meckel-Gerber syndrome, polycystic or dysplastic kidney, Johnson-Blazard syndrome, hydronephrosis and cholestasis, Seagen-Guerdon syndrome in this hydronephrosis and mega-ureter, short limb polydactyly syndrome, glomerular cyst and tubular cyst, Bardet-Biedl syndrome, interstitial nephritis, Neil-Patella syndrome. In this condition, proteinuria nephrotic syndrome is found. Townes-Brocks syndrome, various renal abnormalities are seen. Okay, X-link like Lowe syndrome, oculocerebrorenal syndrome, Fanconi syndrome is associated, orofacial digital syndrome type 1, renal microcysts are involved. In Down syndrome, cystic dysplastic kidney and other issues, Turner syndrome, horseshoe-shaped kidney and other abnormalities are seen. Trisomy 13, cystic dysplastic kidneys. Trisomy 18, similar. Uh, Triploidy syndrome, renal abnormalities are there. Partial trisomy 10q is also associated with renal abnormalities. Okay, this is how we have completed this fluid, electrolyte and renal abnormalities in neonate. It was extensive discussion. Okay, so my suggestion for you is go through this discussion once again, and you will be actually I will be covering 70 to 80% questions which are actually going to come. I hope so in upcoming exam from this fluid alert and nephrology part of neonatology. Okay, so we'll continue this series of ours in in this way also, and we'll cover general pediatrics in audio series. Till then, we'll meet in another video. Do like, share, and subscribe.